respected chairman, co-chairman, convener, and the respected judges. Very good morning to everyone. Thanks for the opportunity. I am going to deal with intumescent cataract, my innovative technique. This is a 24 gauge bent needle from the one side port. I am piercing inside the central capsule, and from the other side I am pouring the visco inside the antechamber to flatten the capsule, capsule. I am relieving the intracapsular pressure by aspirating the cortex in the center. I have made small capsular exits thereafter. Now I am aspirating the mid peripheral and peripheral cortex with the help of irrigation aspiration probes so that the intracapsular pressure is relieved to the extent possible. Very hard cataract. In intumescent cataract, there are 2-3 things we should remember. One is the very high intracapsular pressure that can cause Argentinian flag sign while doing the CCC, and also there may be very hard cataract or very fluffy cataract or very soft cataract. So two types of cataract we can observe. In this case it is a hard cataract. Now this CCC, small CCC, I will enlarge it to a desired extent after making a small nick in the periphery of the capsular axis. Now it is very easy now because there is no intracapsular pressure. There is less likely chances of peripheral extension. So the basic aim is to relieve the intracapsular pressure. In literature, there are many methods which are laid down. Some are aspirating. Some people are doing small capsular exits. Some people are doing punch capsular exits. I have attempted all the techniques, but what I found is that as soon as you enter in the capsular bag through the central opening, there may be or there are likely chances of peripheral extension or Argentinian flag sign because intracapsular pressure is very high. In such a high chamber, you are just taking the nick and it will be burst. So this is another case. Again, I am pouring the visco inside the antechamber to flatten the anterocapsule. Still the pressure is very high intracapsular. So my important message is, while taking the central nick with the help of 24 gauge bent 24 gauge needle, and simultaneously you are aspirating also. So it is attached to the aspiration port also. And from the other side, you are pouring the visco concurrently. That is very important message I want to give. So that the antechamber is well maintained. Now I am aspirating the cortex from the mid periphery to relieve the peripheral or mid peripheral intracapsular pressure. This cataract is not that hard. It's grade 2, grade 3, and the cortex is aspirated. Now there is extension of the capsular axis with the help of Warner's scissor and the capsular forceps. Very easily we can make the capsular axis of desired extent as we do in other cases. So in intumescent cataract, our aim should be to relieve the intracapsular pressure, and that can be very well achieved with this technique where I am pouring the visco from one side port and aspirating the central cortex. Now nucleus management is As usual, again, this is the hard cataract. Thank you very much for patient listening. Thank you.